Okay, are we going? Ready? Okay, so
Yes, sir. I got you.
I'm Dr. Louis Holcomb. We have people in the room and we have people on Zoom, so they're picking up all this. So just kind of quiet. And I would like to thank everybody for joining us. I would like to especially thank Jennifer, who's been instrumental in getting this going every year for the last 12 years. I think we missed a year last year. 2 years, unfortunately. And those were swept away by COVID, like much of everything else. So thank you for joining us, and we'll be putting it on screen share so that the people in the outside can see all that. They won't see me walking around, but they'll see slides. So let's go ahead and do that, and then we will learn how things have changed and not changed in Central Louisiana. Good? Yeah. All right. So you should be able to see the title up there. So good morning, and we live in Central Louisiana, as you all know. It is the public health district here is our 8 parishes in Central Louisiana, and that's important organic and economic whole. And this is seen every year because for 12 years we've talked about one way or another social determinants of health. And the point here is that health is actually a byproduct. It's not an independent variable, it's a dependent variable. And the principal social determinants that determine people's health are income, educational level, and social status. Now there are many others when we look at social determinants of health. We'll talk about housing, access to food, medical care, and a lot of other things. But most of those things are one way or another dependent on the person's wealth, which determines where you can live, what recreational food facilities are there, etc. So this is a very important principle. We talked about this slide. This has been put before. So the drama in Louisiana, of course, is that we have lots of little triangles because we have a lot of poverty. We have a lot of people that have educational levels. And we'll talk about specifically how that plays out because of all factors that determine health. So this is a modifiable factors that influence health, and the reason this is important is that a lot of times the clinical part gets a bad rap because if there's bad health outcomes, it's got to be the fault of the people who are delivering health care. So it's the hospital's fault, it's public health's fault, it's doctor's fault, and so forth. But in reality, over 50%, 40 to 50% have nothing to do with clinical care or even healthcare behaviors. The other thing people say is, oh, it's the people making bad decisions. Well, the people making bad decisions, it's very hard to make that and good decisions if you have no transportation, if you have no supermarket, all those things to go around the people that live in poverty. So 50% is nothing to do with clinical care or healthcare. They're important. So that's where we live. We are a large region, but we're small. But population-wise, we're only about 3,000 people. So we're actually 8 of all of the different regions in California. So everybody's seen this. It's been up every year. Of all the forms of inequality, injustice, and health, injustice in healthcare is the most popular in the name. But this is the one that's not quite as well known. This is our friend William Faulkner, author of many great books. The past is never dead. It's not even past. And he was a resident of Mississippi, which has some of the exact same problems as we have. So this is called the opportunity index. And if it's red or dark red or orange, these are where people do not go out and grow out of poverty. So the area of that has this very characteristic thing that spills over the old traditional South and then up to Appalachia and all that, because those are areas that are very poor as well. They're predominantly white areas. this is the past. This is not even past. Not dead, it's not even past. This was the census in 1860 that showed parishes, counties with from 70 to 100% of enslaved persons. Okay? So this is part of, unfortunately, our southern heritage. And of course, it's all related to cotton, which is all the time. And particularly worrisome goes right up and down Mississippi, where we have many parishes that die. So this is the population in 1860 of enslaved persons, and this is the black population in 2000. What do you notice? It hasn't really changed. So there have been out migrations, late migration with black populations in different parts of the United States. But the concentration of African Americans has remained in its traditional area in the Southeast United States. This has not changed. This is 2000. So if you compare the percentage of enslaved populations in 1860 with the opportunity index, there is a very sad thing. And we will see this over and over. So now we get to 2022 count. So if you're darker green, that's not good. So to have a high ranking is not good. And you'll see that you have this whole swath up here, you have this whole swath here, running up the Mississippi River, and then this concentration around people. And if you put the slave populations in 1860 with fair share countries, what do this? It hasn't changed. This is an astonishing bit of information which anybody who wants to Google it can Google. And this should be the wake-up call to people who live here, decision makers, policy makers. It's not that we've changed, and there has been significant positive change in the South, in Louisiana, in South Louisiana, and other things. So there are things that are much better, but there are things that have stayed persistently bad. Now, you have to put this in the context of America's healthcare, because that lags a year behind because it doesn't connect so early. But this is the America's healthcare. We are, that is it. So since this has been started, and this is a comprehensive evaluation of a lot of different factors, including social factors, we have remained at 48, 49, 58 since the inception of America's health. So when you say that you're number one in Louisiana, or number 50 in Louisiana, your state is 50 out of 50, that is a real eye-opener. Okay? So this is America's health. And you'll see all the ones in the red are probably for 40 or 50, 40 to 50, okay. We have problems. So these are things that everybody knows. Excessive frequency of birth, self-frequency of stress, like birth rates, obesity, etc. We're somewhere in 40 to 50 every single one of them. Now there's a few that are not so bad. That's a good thing. These are behaviors, which elsewhere they call, what they call behaviors. One of the health determinants is about 30%. But you have exercise and activity. Everything in this room is listed. Every single person in this room is somewhere or another to try and correct it. But the error is to say these are all individual choices that people make, but that's why they have problems. Because those individual choices are limited by the social and economic situation. So drinking water violations, the water fluoridation, not people drive to work, local people in the car. And then these are what they call their social economic factors, which are a little different from family. But there's a whole bunch of them that easily has different problems. So this is not meant to trash Louisiana. This is so that people cannot say, I didn't know. Okay, so they know. Not enough journalists, not enough without vaccinations, actually, this we used to be doing pretty well in this, and then there's issues and dropped down. But this was huge. So this is where your kind of outcome is, and they're what they call health outcomes are really only two things: the length of life and quality. So that's the health outcome. And then here's all your health factors here. But again, you'll see that socioeconomic factors are 40%. They're still 40%. The other side has 50, but there's still a big shift. And for these outcomes, so you have length of life, quality of life. And so here's where we all went. So this is all of Louisiana. And we'll look at the individual places. So number one in Louisiana is Henry Parish. What's the wealthiest parish in Louisiana? St. Henry Parish, 53,000 people. Almost nothing. Worst one in is just south of St. Paul. So the rest of it have this distinction are usually Danville or East Parish. And so they are, so there's St. Tammany. Congratulations. Here's Danville. Remember, there were 50 out of 50 in the United States. So you have to put this in perspective. And this means that the St. Tammany out of 3,000 plus parishes or counties in the United States is like 600. So if you're good in Louisiana, you're pretty good. It's good. Right? Not taking away anything from them, but to have problems in Louisiana, low Louisiana is devastating. You are the bottom of the bottom of the bottom, and that is really. So this is really central Louisiana. So we've been tracking this since 2010, so 12 years. And what you're looking for, what you hope for here, is improvements. And improvements would mean it goes down. So you don't want to be 64 or whatever, you want to be at 10. Well, not exactly the same thing. So the three parishes that tend to run consistent. And that's a Royal category and control. And remember, those are the ones that run straight up and down Mississippi. So these are parishes that have had problems since 1860. And I'm not trying to down, there's lovely people there who work very hard and very good. They do a lot of good. And then you have LaSalle and Vernon who are consistently pretty good. They also have the lowest percentage of 14 and 11. Or like parishes on that. But the demographically very different. And of course, Vernon has a big military base, which population is largely a national population. And then you have, Grant and Grant is one of the only parishes that's consistently improved. And, that's the fact. Why that's happened is questionable. There's been a big extension of activities there. Trinity Health has gone out, really has many locations there. There's also been a big demographic shift because people are moving to that piece, they're moving. So there's been a demographic shift as well. And I think that's reflected here. Rapides, where really you have a concentration of medical resources, actually got worse. It's crept up here, almost year by year. And that's not too long. One seems to go again. So again, remember, education, economic development are really at the core of why people have. Yes, they make some bad decisions, but bad decisions are much easier to make to do than bad. So again, really you get the same what we call social determinants of health, which is becoming a big deal in the recent time. So these are health factors we're talking about. I've highlighted the ones in red not because they're more important, because they also show up in America's health. So there's an overlap, but there's not complete overlap. But we have people just randomly felt that this was a smoking thing. And never forget, the first smoke-free ordinance in the state of Louisiana, right out of Alexandria, within the third world country. So policy makes is important, and it makes people. You have big problems. This, so, health factors, they call them the clinical care factors and uninsured. The uninsured is got much better now in the last few years. Medicaid state. And we're the only southern state that, we dropped from, I think we were 17% or something atrocious to less than 9%. So that had in itself had a huge effect on access. So we still don't understand this and hopefully people. And then here's our socioeconomic factors. Fiscal graduation rates, children poverty. So, and we'll talk a little bit about this. Breaking down the vital. So these are health factors. And these are things that end up with health. And you see that the distribution of these are not so good ones is almost overlaid with health. So health factors do result in health. And again, our number one health factors is town. So if you want to move to health care, remember you have to have the 50,000 and here we see the other one. Here, there's this sterile, it has a lot of fish. You can see that the whole area, which is our public health region, it's the only region that doesn't have. Not that that makes it good. Anyway, so these are the health factors. And you'll see that you don't want to be high, you want to be low. You have the Royals Concordia, Petaluma Concordia, these traditional river parishes that have issues. And it's very bad. Then you have the South and Vernon, which do better, but they're not the best in their health factors. So remember the demographics are very good. So when you get to that beach, which actually has the best health factors. So you should have the healthiest outcomes in the bees, but you don't. Okay, so and there are very many people, including everybody who's going to work with this. So that's the factors which lead to outcomes. Socioeconomic issues are predominant in this factor. And then when you look at that, this is first into the brain. The past is not dead. This is. Okay, so we're going to talk about just a couple of the things that are really important. And I'm supposed to go to because there's really hundreds of slides like this, and I don't want to do that. That's quite good. So this is the United States. And see that the median household wealth in the United States is just a dramatic difference. But remember, generally speaking, so this is Central Louisiana. This is 2017. So I couldn't really find it but it hasn't really changed. So it's about the same. And this is Louisiana general. And the pink ones here are white people, and the dark ones are black people. And so it's really easy to read. And the blue is the photo map. So you can see that in Louisiana, not just Louisiana, the United States. So this is one we just saw. If you run across there and your median incomes vary from parish to parish, why is Vernon the people learning this country? The base. And we have a military base there. So we have higher incomes and the third of the population is either directly but a third of the people there are paid with the base. And you can see curiously, perhaps not curiously, it's also a place where these different differences in black and white. It's a lot better off. But you see here in these parishes, there's just enormous differences in English. And this has gone for the early generations. Huge area and why don't we have the concept of average? There are black people who statistical value in that. And that's not a problem. I mean, so it's not evenly distributed in the parish. So this is the darkest areas are households with 63,000 or greater. So these are rich people. So if you look on that, see where you live. There's a lot of rich people here at this time, especially here in 2011. Really important. If you go to you'll see there's this concentration in something. This is part of the grant or tax. You have this big chunk here in kind of here in Louisiana. And then you have these other parishes, especially southeast corner of Florida, which is very sensitive. But then this is not equally distributed. It's concentrated. And compare areas where there's high income, areas where there's poverty, it's hard to see that, but they're almost very interesting. So, I mean, it's not surprising that they're not similar. So, they calculate something called economic inequity, which is based on the differences in salaries and so forth. And of course, Louisiana finds itself with its southern neighbors having a very high income. So this is particularly a problem because kids live in poverty, they have lots of educational issues, they do not attain attainment, they have lots of health issues, lots of ACEs, stuff. And that's actually decreased. This is decreased. This is not new to have. This is 2017. And actually, I'm not part of the permanent poverty. What happened that we had a significant reduction in childhood poverty? It was all the funding, the child tax credits. And so 40 million kids were brought out of poverty. Of course, that's in. But it was very good. So we're getting down to Mrs. Franklin's expertise here, which is schooling. And so this is the intent for schooling for the top. So it's red, that's good. Similarities between this and all these other slides that you've seen. You can literally put them over each other. And it's just there. Pardon? So anyway, so that's okay. So I'm going to talk about education because education is the other critical component of getting people out of poverty. And we're in high school graduation, we're still here. So population first high school graduation rates, the Royals Parish is right there. You see that same distribution. Oh. Yeah. Pardon? Oh, you.
Well, or I can speak into that. Okay, do you want me to just talk into this mic? Okay, so you can hear me? Okay, well, I'll just raise my volume. Okay. So anyway, this is again the percentage of people without high school education. You see, you have this same distribution over 25. So these are people who are young adults, they didn't have an education. So this is the darkest areas here. The run up in the same parishes are without, they don't have a lot of choice. So this your potential of money that you can make in your lifetime is almost entirely dependent on almost entirely. So is that equally distributed? Well, not exactly. So these are people without high school diplomas or their equivalent, and this map is almost completely you can overlay it with concentrations of people in Louisiana, which in our area is, there's only 2% Hispanics. This is on the entire map. So these areas are the same areas. So school funding. This is where we get into Franklin's expertise. Yes. So this is the percent of school funding at it's federal. And if it's this one is 30, the blue is like 29 to 20, 25 to 35%. So if it's green, it means there's a high percent, at least a third of the funding comes through the federal government. So you can see that again, you have this concentration, but we're not the only culprits here. It spills over and runs on both sides of the Mississippi River, all the way up through Mississippi, all the way to Arkansas, in the same areas that you saw in the 1860s. So a lot of that is federal funding. So like that's good. Like you guys are stepping in to address this problem. It's all good. Well, this is school funding adequacy among U.S. counties in 2019. So they're doing it. They're helping, but they're not helping enough because they still don't have it. And so you have this whole area here, which is deficits, and that's the inadequate school funding. Look at the distribution. So if you want to make any progress in any of this, you got to correct some of these underlying economic and educational inequities, or you're just going to stick with that same deal on and on. So this is a little update because we had COVID, kids had to work from home, they needed broadband, and guess where we have less than 15% broadband. So same area. So not only kids get kicked out of school because of COVID, but they couldn't do broadband, and they didn't have access to broadband. So this has had a huge negative impact on education. So it's all mixed up. It's all same stuff. Child care cost burden is a percentage of household income. The dark purple is their child care cost is 38 to 44% of the household income. So these people, the folks in these areas are spending a lot of money on the kids, but still a problem. So this came out of county health ranking, and this is a little joke, it's not that funny. But you have these two people, and the guy says, what's the matter? It's the same distance. And so it's the same distance, that's fine, but if you have to jump over barbed wire and alligators, it's a little bit hard. So ultimately, all this gets down to our health outcome of people life. And how people live. And here, all the red things are place counties, parishes that have less than the national average of life expectancy. And my bad. So
Muffles better. They just.
oh, now they want to louder. I can carry the darn thing in my hand. Okay, so I'm yelling in the mic. So I hope it's loud enough. I'm sorry, we haven't quite mastered technical ability here in central Louisiana. But the life expectancy maps and this map are also, again, suspiciously comparable. And life expectancy in 2018 was 75.6 years in Louisiana, and nationally was 78, which is much, much less than our developed peer countries in Europe. They're up in the 80s. So what happened here? There's these big differences in life expectancy, but this is US total, of which African Americans are only 14% of the US total population. In Louisiana, they're 35% or more. So there's always these huge differences. So a white woman is likely to live 4 years longer than a black woman. A white man is likely to live 4 years more than a black man. And there's all sorts of factors that go into there, but their life is predicted to be shorter. So this is what happened with COVID. So COVID just knocked people out. And it was especially severe in the beginning part when there was no vaccine, no nothing. And there was just these stark differences in mortality between African Americans and whites. And we talked about this at the Disparities Conference, you know, some of the reasons why that all happened. But it did have nationally an enormous effect. And of course, the predominant effect. Now, what they don't see here is going into 2021, it turns out that the white life expectancy is continuing to drop, albeit more slowly. And the black life expectancy stabilized. Now remember, in Louisiana, and in August, there was this shift where the black population rate of COVID vaccination started to exceed the white. So things have happened, and unfortunately, a lot of it has been tied up to reactions to COVID and so forth. Anyway, so we dropped. We continue to drop as a nation. So this is life expectancy at birth, and the darker areas are a life expectancy between 77 and I can't read that 81. So I mean the lightest areas have the low. I'm sorry, it's backwards. The lightest areas are where you have the lowest life expectancy. So you have here that same area, pieces of Rapides here, pieces of Vernon. And this is areas where you have the most poverty in the populations. They're not perfectly superimposable, but it's pretty good. So it's not only you don't live longer here. If you're a baby, you're more likely to die. And nationally, it's a lot less. Okay, so we're not the worst here. Our infant mortality, actually, region 7 is Shreveport area. So we're not doing too badly, but it's a 2-to-1 black to white ratio. And this is the US infant mortality, and this is all other developed countries. So the US is really lag behind. We're doing somewhat better than Turkey and Mexico, but I'm not sure that's our standard of comparison. And this is Rapides Foundation information, and this is annual infant deaths, and this is 2014 to 16, but it hasn't, I don't think it's changed appreciably. You can see that it's almost 2-to-1 ratio. That's our region. And then maternal mortality is not much better. Well, it's actually even worse. 4 black women die for every white woman. So this all affects mortality, life expectancy and stuff, although that's not the predominant factor. So we've talked about this, the areas where there's, greater than 20% poverty, there's a significant overlay with education. These maps were developed in the COVID to try and find areas where we can give vaccinations, and it's called a social vulnerability index. And so these areas were the areas that were identified with the highest SVI per parish. So you can see the little spots here, and they're all places everybody knows. That's a close-up. You see there were pieces of Alexandria and the other bits and pieces here. And then you've already seen this, but it's so striking. I just have to put it up again because it just, ugh. So this is about concentrated disadvantage. And this is where they compared two places in Louisiana and in Alexandria. So you have the Sonia quarters, and this is what, a mile away, maybe 2? I don't know, it's not far. And in Wilshire Park, and this is probably shifted to the worst, actually. 7.3%, well, this is the good part. 7.3% below poverty, 8% on public assistance, only 1% unemployment. These may have shifted because this was done a few years ago. Female households, 25%, et cetera. And you go over to the Sonia quarters, and you get at least almost 40% of the people in below poverty, at least a third on public assistance, at least 10% unemployed, 60% female households, and a much higher concentration of young people. who are going to school, I might add. So you have these two places that are adjacent and have, if you're in an area where it's a disadvantaged neighborhood, twice as likely to have a low birth weight, 1.5 to be preterm, 2 times as likely to die before the age of 1, 35 times more likely to be in poverty, 3 times more likely to have a child as a teenager, twice as likely to be unemployed, and 4 times likely to need public assistance. And remember, all of this is what will ultimately determine your health outcomes. So concentrated disadvantage, everybody can recognize it. It's where you have more crime, more liquor stores who sell tobacco and alcohol, sometimes limited transportation. We do have it in Alexandria, but no place else. You know, there's just a bunch of problems. You have rent to own and payday loan. And I mean, everybody knows these places. You drive through them, you know, you can recognize exactly what it's like. And then you have nicer areas that have nice parks and all that. And there are people try and address these issues. Then we have things like obesity, and the lower your income, the higher your percentage of obesity. And obesity is why people get diabetes and then get heart disease and then die. You know, I mean, there's no big, and that's Rapides Foundation. Then we have all this stuff that's just gross. We've had an enormous increase in sexually transmitted disease, notably syphilis. It's increased in women 62%, 54% of the cases in women. And, you know, for a while we had the highest rates, and women, if you have more women in childbearing age, you will have more congenital syphilis. And our cases of congenital syphilis double. So the Office of Public Health is working on this as best we can. But when you drill down to, you know, what's driving all this, there's a lot of poverty and problems. So I'm not really going to go into all this because you're going to get cross-eyed. But, you know, dark areas have 19 cases per 100,000. You see, it's not equally distributed. They do not go down to census tract because that's a little tricky. Okay, so they do it at parish level. Gonorrhea cases up, chlamydia is somewhat stable. And then COVID blasted the place, the whole state, the whole nation for everything associated with overdoses. This is Rapides Parish, 2021, 72 deaths. And this was a lot, this is Rapides Foundation, but it grossly underestimates, but also shows that it's a more of a problem in lower income. And it's not really the doctors this time. Doctors helped create this problem, but they didn't really perpetuate it. So there's been a big drop in opioids, but this is a complicated slide, but these are by month. And then the little orange squares are deaths. And this is 2018, 19, and 20. So you can see what it's done everywhere. This is same problem, fatal overdoses, first quarter, second quarter, third quarter, opioid deaths. This is Louisiana, fatal. So anyway, and so it's also caused a lot of problems with this, which is mental health issues. And the suicides and the overdoses this has all been greatly aggravated by COVID and has hit our area. But I'm not, this is a whole separate thing about firearms and deaths and suicides and stuff. So I'm not going to go there today because it's very treacherous territory to talk about firearm deaths. But needless to say, we see a lot of them. And young Black men, the leading cause of death is homicide. Young white men, the leading cause of death is car accidents. So there's a real issue there. Okay, so suicides. I guess the only bright spot in this is that there's a bit, Black people in general don't kill themselves. Yeah. Okay. Well, I'll give you your chance here. So anyway, we're going to do so well with that. So violent crime, lots of violent crime. But this is years. This is the United States in general, and our firearm suicide rates have gone up. This is 2020. They've continued to rise, and firearm homicide rates just took off. And firearm homicides, there was a huge racial disparity between whites and Blacks. Yeah, I mean, it's striking. So remember, income, education, and social status. I'm turning it back over to our Tobacco Free Living, which is our sponsor, and she will make a few comments.
Oh, okay. Which one advances?
This one advances.
Okay. Let me X
You
marks the
you don't have
spot.
to, you don't even have.
Oh,
to,
it doesn't
because
matter?
it's-
Oh, okay. Can y'all hear me? I hope. So I just want to say thank you to everybody in this room for the good work you do. We all work on these issues, and sometimes it's a little discouraging to see this. But it makes a big difference, because even if we move that needle a little bit, it makes a big difference. So onward and stay steadfast, and we'll keep on plunging away and making these numbers change in our state and in our region. So thank you very much for the work you do. I just want to quickly address this. We have a slide that just came out with Tobacco for Living on this exact issue, which is tobacco use and social determinants of health, and structural determinants of health, and monetary impact on the state and impact on lives. So it's exactly what Dr. Holcomb just discussed. And it talks about how, the poverty, the education, and all of the factors. So I'm not going to go through and beat this horse to death, but just know that it impacts, all of your areas, whether it's opioid use or mental health. All of these social determinants of health have an impact on whatever area we're working on in public health. So I want to go ahead and advance and talk about what the work is of tobacco-free living. And Dr. Holcomb alluded to this, and he said, when we have policy change, that helps people change their behavior, because it's law, because they don't have the ability to smoke indoors and expose other people to secondhand smoke, which can cause issues not only to themselves, but to the people around them. And so we're excited to just go ahead and say, a lot of y'all know this pitch. You've heard it for a long time, but for those in the room that have not, the state law passed in 2007, Act 815, which took smoking out of most indoor places, but they exempted gaming and bars and a couple other places, but those are the two big venues that were left out. And of course, that's where a lot of people go and hang out. College students work there to make extra money. Sometimes mothers have to take extra jobs just to get additional income. And those people should not have to sacrifice their health because they work in those settings. So the great thing that the legislature did was they repealed preemption, which lets us strengthen the state law at the local level. So thank goodness for that. And we're still in the 10-year anniversary year. We had a big press conference here in January celebrating that. Alexandria was the first to do that. I'll recognize Roosevelt Johnson over there. He was city council president at the time, and worked with us, and all the coalition members in here who have participated in this work. So we now have 31 statewide. Took 10 years to get 31 ordinances. It's hard work, it's challenging work, it's slow work, but it makes a difference. So now we can say that what we have is 30% of the state covered completely by secondhand smoke, from secondhand smoke exposure. But like we just went through this PowerPoint with Dr. Holcomb, that's not enough. We want the whole state protected from secondhand smoke in the workplace, and no matter where their job is. And so we still have a lot of work to do. We got 70% to cover. Hopefully that will be done by state law at some point soon. But this is where policy work can make a difference on those behaviors that hopefully will in turn protect and change the outcomes that we see here on our slide. So thank you, mine's short. Mine's short, it's quick. But thank you everyone for the work that you do. I know it gets, difficult sometimes to just plunge away and feel like, the needle is not moving, but we appreciate it. And I'm going to call on Ariana. She's with the Office of Public Health. She wants to go through a survey with all of us to get your feedback and to get your response to what we talked about here today. So thank you.
I don't think I need it. Good morning, everyone. I am Ariana Alexander. I'm the regional strategist at the Office of Public Health, and my role is to partner with community organizations and work to close the health gaps within our communities. Some of the work that our COVID team has done thus far over the last couple months includes working with Roll Sleeves Up to host the Rural Health Summit in Marksville, Louisiana. We also have created health disparities assessment tool to assist individuals in our community with accessing services available for them to improve their everyday living. We've also partnered with Well Ahead and Bring Back Louisiana to provide swag bags for 2,500 students in Avoyelles and Rapides Parish. So we've got plenty of things that we're working on, but we need your help. So now you will have a deep, meaningful conversation with the individuals at your table. In the center of the table is the survey that we would like you all to discuss and complete. And then also there is a community cares commitment card. It's just a card that I want you to complete to commit to doing one thing in the community. That could be starting a diabetes support group at your church. That could also be organizing certain events within the community. It could also be donating a monetary gift to an organization here in town, becoming a CASA advocate. So I want you to complete your commitments and also include your name and contact information because I'll be following up with you. Any questions about what we're doing this morning? Also, if you're participating via Zoom, there's a link there for you to also participate. And we look forward to your feedback.
All right, well, I would like to thank the people that came in for Zoom. And if you're interested in any follow-up or getting some of these depressing slides, I will certainly, pardon? Yeah, so we'll get those out. There's more on there that you can use. It's sort of a reference thing. And so thank you, everybody, for coming out there and here. I would like to introduce the new regional administrator. I used to have the title Regional Administrator Medical Director, but now I'm just the Regional Medical Director. And I would like Dr. Lewis to come up and just say hello.
Just speak loudly.
Good morning, everyone. I'm Dr. Curtis Lewis, Regional Administrator of the Office of Public Health. I'm just excited to have in here and assist in better living, former educator, as well for you folks in the services. So here to support in any way possible and really make an impact.
Yeah, thank you, Dr. Holcomb, for everything. Are we out? Whoops. No, I thought that was. So are we done? We're done. Okay, good.
Thank you all. Y'all, there's more food if anybody wants to.